So we will jump right in. What I'm going to try and do today is cover some of the common psychiatric conditions. The most common ones that overlap with narcolepsy are depression and anxiety disorders, but we'll also briefly talk about schizophrenia. We'll look at their diagnostic criteria, how that might overlap with narcolepsy, and we will also look at medications that are used to treat these conditions. And again, there is a substantial overlap there with narcolepsy. And we'll are going to save the Q&A till the end. So all three of us speakers first. So to kick us off, major depressive disorder, MDD, that's what we call it in psychiatry. The main takeaway here I want people to leave with is that it is not sadness. Sadness is a natural emotion. It's something we all need to feel. It is something that's part of life. Major depressive disorder is conceptualized as a disease of the brain. There is this substantial difference in terms of what depression is as compared to sadness. It is this pathological state, and when we are looking at it, the intensity, the duration of the symptoms, timing, quality, all of those are very different from sadness. Its expression and appropriateness are also different. And sometimes in practice, especially in following grief or other major events, it can be hard to tease these two apart. So we use a lot of mnemonics in medicine. SIGECAPS is the mnemonic we use for all the symptoms for major depressive disorder, and you can see what all of those stand for. I've bolded the ones. The main thing in depression is this sad mood, which is of a different quality that lasts for 2 weeks or longer. That associated with what in psychiatric terminology is called anhedonia. And anhedonia is this lack of pleasure in things people previously found enjoyable. So that lack of pleasure, when both of those occur, that's usually a clear signal for us that we're likely dealing with major depression. And you have all of these other symptoms too, so reduced energy, worthlessness, suicidal thoughts, guilt, all of that. From a narcolepsy standpoint, there is this overlap with sleep disturbance. About 80% of people with major depressive disorders will have insomnia. About 10 to 15% actually present with hypersomnia, so excessive need for sleep. So there is this overlap there with narcolepsy. It is an extremely common psychiatric illness, one of the most common, in fact. Roughly about 20%, and in some cases 16% of the population will in a lifetime. So 1 in 5 will have a diagnosis of major depression. It's most common between the ages of 25 to 44, and the usual mean age of presentation is roughly 30. And it is the fourth leading cause for disability worldwide. So again, a lot of morbidity that's associated with major depression. Treatment for major depression usually comes in the form of 3 different avenues for us. So there are medications, antidepressant medications. Sometimes we use mood stabilizers as augmenting agents, or also antipsychotic medications as augmenting agents to enhance the effectiveness of antidepressants. Then there are talk therapies, and then the other treatments which we reserve for much more severe depression. There are things like ECT, transcranial magnetic stimulation, or TMS, and more recently, ketamine infusions. So when we are talking about cognitive behavior therapy, there are many different treatment options. So cognitive behavior therapy is the most common. So cognition is thinking, changing how people are thinking about their current situation. Behavior is changing how they are reacting or things they're doing about it. And we try and put both together, and we'll talk a little more in a little bit about what the behavioral treatments can be. Interpersonal therapy, where a lot of the focus is on relationships. Then there is supportive psychotherapy when people are going through some difficulties with specific situations, offering them solutions to solve that. And the old Freudian psychodynamic psychotherapy is still an option, but much less used now, just less effective, much longer course of treatment that's required as compared to some of these, what we call new wave therapies. Exercise is actually an excellent treatment for depression, and moderate exercise 3 to 5 times per week, about roughly 45 to 60 minutes, so much more than the normal recommendation. So increasing that a little has been shown to be effective, at least for up to moderate depression. Behavioral activation and activity scheduling are part of cognitive behavior therapy. So when people are depressed, the way they react to it is they do less, they sit in a place, they don't want to do much. And then you start actually getting them to move around, do things, stay active. So breaking this conception that I will feel better and then I will start doing things, and flipping it around to I will start doing things, therefore I will start feeling better. There is also seasonal affective disorder. So usually it's depression in the context of fall, winter months, and more elevated mood in spring. Their light boxes are quite helpful in treating the depressive side of things. And it can also actually help quite a bit with sleep. So those are the non-pharmacologic treatments. Anxiety disorders, so the other major group. And when we look at anxiety disorders, there are a lot of subcategories within that. So there is what's called panic disorder. So panic attacks are where you have this sudden intense burst of anxiety. There is this heart palpitations, tremors, butterflies in your stomach, all of that. And with a panic attack, these episodes come on, and in a panic disorder, there's no trigger. So they're out of the blue. They're usually associated with what's called agoraphobia. Agoraphobia is just fear of being in places that you can't quickly get away from. So both of these tend to run together. Specific phobias, you have anxiety, but it is to a specific thing. So heights, snakes, spiders, clowns, name you. Anything can cause a specific phobia. Social phobia is, of course, phobia in social situations. Actually, it is one of the most common psychiatric illness apart from major depression. Then there is PTSD, post-traumatic stress disorder. So usually you have a major traumatic event. The trauma is usually life-threatening for you or a loved one. And then you have three clusters of symptoms. So one is you're reliving that trauma, either as flashbacks or nightmares. Two, you're avoiding everything that gives you some recollection to that. And three, you have intense anxiety built in. So those three go along with post-traumatic stress disorder. When it is between 3 days to 1 month following the trauma, we call it acute stress disorder, because a lot of people will have that, but within a month, vast majority will sort of adjust, cope, and that goes away. When it persists beyond 1 month, that's when we make a diagnosis of PTSD. Generalized anxiety disorder is just low-level, low-grade anxiety with no clear trigger, which can interfere with quality of life. So here too, the treatments are one, cognitive behavior therapy, especially what's called exposure-based therapy. So with specific phobia, it's easy to understand, but even with panic disorder, what we try and teach our patients is first relaxation skills, so how to calm yourself down, and then you expose them to that stimulus, whatever is causing the anxiety. So the way we conceptualize anxiety is each time something is causing anxiety, our natural predisposition is to avoid it. And the more we do that, the worse the anxiety gets and the more power it has. So what we teach patients is to sit with it long enough where the anxiety peaks and then falls off. So over time, it does not have that power over them. Sometimes we use benzodiazepines, so Ativan, Klonopin, those class of medications, Xanax. They can be effective as bridge therapy. We try to avoid it long-term. The main thing here is that it can cause some sedation. So you want to try and keep that in mind in terms of how it can impact narcolepsy. There are a lot of antidepressants, which are also anti-anxiety medications. So they tend to get used here too. Usually you are looking at higher doses than for depression, and you start low, go slow, because if you go too quickly in these situations, you can make anxiety worse. We'll very briefly cover psychosis. So schizophrenia is the most common among these conditions. It's still quite rare. It's only about 1% of the population. Usually you're looking at 2 or more of these symptoms for 6 months. So delusions, which are these false fixed beliefs, hallucinations, which in schizophrenia are usually auditory, not visual, disorganized speech, catatonic behavior, negative symptoms like this flat affect, so really not reacting to things, being immotivated, not doing much. It's usually going to start in teens, and that's the peak, but up to 30s is when it tends to initially present. It's equally common in men and women, but in men it tends to occur a little earlier than in women. And usually before these symptoms develop, there is this decline in function. There is also an increased risk of suicide, like with depression, with schizophrenia as well. And that's usually in the first few years of the diagnosis. That risk goes down as people sort of get older. Here, you're looking at what are called antipsychotic medication or neuroleptics for treatment. The main thing here to keep in mind with these medications are that one, they can cause sedation. Two, a significant portion of the newer drugs don't cause as much sedation or other side effects, but can cause weight gain. So that can make sleep apnea worse. So why worry about it in the context of narcolepsy? There is a substantial overlap or comorbidity between psychiatric conditions and narcolepsy. So a lot of people have both. There is also this theory, at least, that there is a shared etiology. Orexin or hypocretin system, which by now you understand is integral to the presentation of narcolepsy. We know that it also plays a major role in regulating people's moods. It also has a major role actually in addiction too. So it has all of these overlap from an etiology standpoint. And a lot of the medications that are used have sort of overlap in terms of being used for narcolepsy or sometimes having some side effects that can make narcolepsy worse. We haven't talked about ADHD, and I'll come back to that in a little bit, but there is a substantial overlap both in terms of symptoms and medications with narcolepsy and all the other conditions that we talked about. So in this study, which is the famous BOND study or the burden of narcolepsy, patients with narcolepsy, you can clearly see those who have narcolepsy who were matched with non-narcolepsy controls. About 20% had anxiety as compared to 7% in the general population. 25% had mood disorders or depression as compared to about 6% in the general population. So psychiatric illnesses tend to be more common in patients with narcolepsy. When we're trying to sort of separate this out with depression, there is this overlap. And again, a lot of times what you're trying to do is get a clear history, understand the context, so you can try and tease these apart. So with depression, you have the fatigue, lack of energy, which can masquerade as sleepiness. You have difficulties with sleep initiation and maintenance, not the fragmentation, but again, some overlap there. There are changes in appetite and suicidal thoughts, which we tend not to see so much with narcolepsy, but there is also this withdrawal from friends, family that can happen with depression, sometimes with narcolepsy too. So you're trying to put both of these in context when trying to figure out what is going on in your patient. And with schizophrenia too, there is again, with medications and even without, some excessive sleepiness during the daytime. There is again sleep disturbance. The hallucinations in schizophrenia tend to be much more auditory, so they're hearing things. With narcolepsy, especially hypnagogic, hypnopompic hallucinations, they tend to be either visual or multimodal, not just auditory. And some of the other symptoms too could overlap between the two conditions. In terms of medications, we can see with ADHD, you're using stimulants, and with anxiety and mood disorders, you're using antidepressants, so SSRIs, SNRIs, which are the venlafaxine, duloxetine, or Effexor, Cymbalta medications, the older tricyclics. They're also quite commonly used in narcolepsy. And the antipsychotics, like I talked about, side effect burden can be high in narcolepsy patients. With antidepressants, they're commonly used to treat cataplexy symptoms off-label. The older ones, like tricyclics, were most commonly used. Tricyclics had a worse side effect profile. So they would cause a dry mouth, constipation, sedation. So not particularly clean drugs to be used for this. Still sometimes occasionally get used. But the newer ones like the venlafaxine and duloxetine, so Effexor, Cymbalta, are commonly used because they are less likely to cause these problems. But they can increase blood pressure and usually are associated with GI problems. There are also common sexual side effects. Usually anorgasmia is quite common with both of these medications, so we run into that. With antipsychotic medications, again, they're causing sedation, they're causing weight gain, both of which can be problematic in your patients with narcolepsy. With ADHD medications, the first-line ones are methylphenidate or Ritalin, stimulants such as Adderall. Very effective to treat ADHD. They also are wakefulness promoting. So there is this common use for these medications. In both conditions, they have similar dosing profiles and side effect profiles. With narcolepsy, we tend to use slightly higher doses. So we tend to run into a few more side effects than with just ADHD. The newer ADHD medication, atomoxetine or Strattera, is not stimulating, so that does not have an added benefit of promoting wakefulness when people are using that. Benzodiazepines, we talked about this. The main concern here is sedation, sometimes used to treat anxiety disorders. The one final thing to keep in mind is when we are trying to do the multiple sleep latency testing, so the daytime nap studies to test for narcolepsy, with antidepressants, what they do is they suppress REM. So we tend to not see these sleep onset REM episodes that we need to see to diagnose narcolepsy. Antidepressants also can impact how quickly people fall asleep, so the latency changes. So we are ideally trying to get patients off these medications at least for a week. Sometimes 2 weeks is preferable to try and make sure that the test is not compromised by having these drugs on board. And benzodiazepines and antipsychotic medication can make people sleepy. So again, it's hard to interpret how quickly people have fallen asleep if they're on these medications. So just to summarize, we've talked about how mood and anxiety disorders are extremely common. There is a substantial overlap in terms of medications that are used to treat these conditions in narcolepsy, and these medications can have implications both in terms of symptom profile, making people sleepy, gaining weight, causing sleep apnea, or interfering with testing. And from a clinical standpoint, when we are seeing patients who have both these conditions, you want to address both, make sure you treat both to get your best results. So with that, I'll hand off actually to Dr. Carvalho, and we'll take questions towards the end. Thank you.
Okay, good afternoon. We're going to talk now about narcolepsy and some medical issues that can go along with it. The hope is not to scare anyone, but mostly to show what could happen and why you patients with narcolepsy may be at increased risk. So things that we need to be more careful. So we have learned that orexin is an important chemical in the brain, not only to maintain alertness, but also to regulate eating behaviors, how much energy we expend, so which is connected to our eating patterns, and also potentially regulate our autonomic system that regulate our blood pressure. So when there's low orexin, a decrease in this chemical in the brain, we think that it could give rise to some issues like this, like obesity. Not surprisingly, upon diagnosis, a lot of kids in particular, but also adults can present with a weight gain along with the sleepiness, but also increase in blood pressure and metabolic changes like diabetes. Now, reviewing the literature on this and the research, we know that it's not only narcolepsy type 1 patients that will be at this increased risk of these conditions, but also narcolepsy type 2. So we won't be able to blame everything on this, on the orexin. There's more going on. And one of the things is the poor sleep quality, the fragmented sleep that is typical of narcolepsy. We need a good deep sleep to lead to that dip in blood pressure. This natural dipping of blood pressure and I has been found to be a significant predictor. So the lack of the dipping is a predictor of the of developing hypertension down the road. Okay, so and then when you have sleep that is disrupted, poor quality, along with the tiredness, the daytime tiredness, there is more craving for sugars. There is issues with regulating our sugar in our bloodstream. There is sometimes we're having trouble with making eating choices, right? And we may go into high carb, high fat meals. Those things can contribute then to high blood pressure, obesity, diabetes, and sleep apnea. Now, we cannot also blame everything on the poor sleep and take our choices away, right? We do have a choice. We do have patterns, lifestyles that we follow. So, lack of exercise, not being careful about what one eats would also contribute to the problem. And we need to be paying close attention to it. And indeed, medications, if you look at it, all stimulants can potentially increase blood pressure. Will that necessarily be the case? No, it won't. but it could happen, and some of them would also potentially cause, particularly a certain dose, palpitations, heart rhythm abnormalities. So it's something that we need to keep a close eye on. One thing about the medications that are different than the other process that I was talking here is that, not uncommonly will suppress appetite, and by suppressing appetite, we can lead to weight loss. Or what is more concerning in this area is mostly in the development rate of kids and teenagers, where we want them to grow, right? And then we need to be extremely cautious about that, and pay close attention to their eating habits and patterns. So this was a major study. Look at thousands of patients, and have detected, an increased incidence. So this is over time how many patients develop some cardiovascular medical problems, and we see, significant increase in things like stroke, heart failure, atrial fibrillation with a heart rhythm abnormality, and also heart attacks and other things. So it's not negligible, that increase. And the study had limitations. It didn't really, it was not able to control for medications that patients are on or doses that patients are on. But it does raise a concern that patients with narcolepsy have an increased susceptibility to cardiovascular disease. Now, when this other study was very nice because it reviewed all the literature on narcolepsy and other comorbidities, other disorders. And we have to understand this as an association, right? So narcolepsy have been associated with a lot of these disorders, whether there's causation or not, whether narcolepsy is the cause of it or not, we're not sure. I mean, a lot of those things we're not sure. We guess there's maybe a role, but there's much more to learn. But you can see, clearly that the mental health issues come with a lot of publications in this field, connecting narcolepsy to that. And patients with narcolepsy can have depression. Depression can be a result of narcolepsy. It's just like those things there's so much overlap. And then also endocrine issues, in particular thyroid disease, Hashimoto's thyroiditis, high cholesterol, as alluded to, the diabetes in particular. And then there are some other conditions affecting sleep that we see, and Dr. Erik Lewis will focus on that as well. But sleep apnea is a concern, particularly when you think about cardiovascular health. Some other conditions that we don't know as much how and why they're combined, but migraines come here, some pain syndromes come here, and we know there's this a two-way street with sleep and pain, that poor sleep may decrease pain threshold. The circulatory problems that we're talking about already, and even some potentially, other immune disorders. I alluded to the Hashimoto's, and also asthma or allergies may be related. And then I don't want to scare anyone. There's some more obscure relationships here that we are far from understanding whether that is significant or not. We have to study more to know. So here is from our Olmsted County, our very Olmsted County information. So we're able to review our Rochester epidemiologic project here. And then we see here upon diagnosis, and then more like after long-term assessments, what are the medical comorbidities that patients with narcolepsy have in comparison to controls. And we can see, there's several disorders that come more frequent in narcolepsy than in the general population. And most of them that are already alluded to. But you can see here, depression coming up pretty high, but obstructive sleep apnea not too far. And then long term, we see all of those things in addition to, some other conditions here, the headaches and something that we cannot never, we have always to we always have to pay close attention to, which is, trauma related to motor vehicle accidents, right? So what do we do about it? There are things that we can change, there are things we cannot change, but we can focus on the things we can change to try to reduce the risk of having problems on their own. None of this happens overnight. So we need to be careful. Exercise is good for sleep quality, is good for cardiovascular health. And the American Heart Association recommends 20 minutes of brisk walking per day. That is something that most of us can fit in our schedules, right? Or 150 minutes of a moderate intensity exercise per week, 75 minutes of high intensity exercise per week. Those are the most recent recommendations. So things that if we can make it a routine, we can make it feasible. Now, in terms of the diet, reducing salt. I mean, the data on the salt, it does show that there is an association with an increased incidence of hypertension. I think this is hard to refute. Now, once you have high blood pressure, whether reducing salt causes significant decrease in blood pressure, that there is a decrease, but whether that is clinically significant is another story. But but some things to be careful about, and then also saturated fats, mainly your fatty meats and cakes and sugary foods, right? Our sweets. I mean, we don't need to completely eliminate those things from our lives, but we got to be cautious about, particularly eating those things every day and trying to limit it if possible. The good sleep habits, as we discussed throughout this conference, right? Regular sleep, give enough opportunity to sleep at night. I know some patients with narcolepsy, they want to do the third shift. They want to do like a side job in a bar, and they can do that because they're on stimulants, and then they're not getting enough sleep at night, and they're getting through because they have the stimulants to help them, but not having enough sleep is a neglect to their health. So no, obviously, alcohol, drugs, tobacco, those things are very harmful for cardiovascular health and for overall health. And routine checkups are important. I mean, I don't like to see doctors. Most of us don't like it, but we have to. And when it comes down to narcolepsy, that becomes even more important. The blood pressure is one of the main things. And overall, the recommendation is a blood pressure below 130 to 280. Okay. And if that's going above that consistently, then one can start paying close attention and maybe intervening with some first non-pharmacological strategies. Let's losing weight sometimes. And that's sometimes losing weight can definitely bring someone down a little bit, but sometimes you eventually will need treatment. And then particularly after starting medication, they become even more important. We know that starting medication, the incidence of hypertension increases. Now, the keeping a close eye on the cholesterol, the blood sugars, right? Thyroid function are also reasonable. So in some situations, an EKG will be helpful as well. And then if we establish that there is a medical problem at hand, I mean, treating it and not like overlooking it to be important with, whether it's going to be weight loss or sometimes a very careful diet so that the child it continues to gain weight and develop normally. Blood pressure medications, anti-diabetic medications for sugar levels. There's sleep apnea. One wants to treat that as well. And in particular, I mean, we are human beings. We have our physical health, but without mental health, right? Those things do not work. So we need to always pay close attention to mental health as well. So I'll pass along to Dr. Sean Lewis to go further on the sleep comorbidities.
Well, thank you all for your attendance and engagement here today. It's terrific to see so many people who took the trouble to come here to Rochester, and those of you joining us online. I'd also like to thank Ms. Gao, Ms. Anderson, and the good folks at Wake Up Narcolepsy for the invitation to speak today, and to Drs. Carvalho and Bond for helping organize such a terrific symposium. Here's the slide advancer. Great. So I've dubbed today's brief talk the night shift in narcolepsy. And just like I think in the general population, we forget the forgotten third of life really is sleep. It's sort of the forgotten part of narcolepsy. Way back in the day, famous initially works done here at Mayo Clinic in narcolepsy by Luman Daniels in the 1930s and Later, Bob Yoss in the 1950s coined the phrase of the tetrad of narcolepsy. I think this exemplifies the four symptoms that we think are the very hallmarks of narcolepsy, those being excessive daytime sleepiness, cataplexy, hypnagogic hallucinations, and sleep paralysis. And of course, not every patient has all of those elements, but those are considered the classic findings. But recently, over especially the last decade or so, people have started talking about a pentad of symptoms of narcolepsy. So that additional fifth symptom is that of nocturnal sleep fragmentation. Because just like there's intrusion of sleepiness into the daytime for patients, influences sleep, and then some of the comorbid sleep disorders that also affect sleep quality. And we can think of these sleep comorbidities as a lot like the sidecar of a motorcycle. It's not the main part of the vehicle, but it's frequently attached. And when it is, it's hard to get rid of, and it sort of deserves its own attention. So we'll try to take that focus today in the talk. These are my disclosures, none of them really relevant to this presentation. And my hope is that you'll become familiar with the sleep disturbances that are distinctive within narcolepsy itself. Those comorbid sleep disorders that are particularly frequent in narcolepsy patients, and these include sleep apnea, restless leg syndrome, and the parasomnias, which are peculiar behaviors arising from the sleep state. And then we'll talk about some of the treatment approaches or considerations, at least, for these other disorders, as well as within narcolepsy itself. So let's start with narcolepsy and this pentad symptom of disturbed sleep resulting from the illness. We think this really is part of the hallmark of narcolepsy, and it's at least in narcolepsy type 1, with the state of orexin or hypocretin deficiency, which you learned about from Drs. Juna and Silber earlier today. Hypocretin or orexin is one of the key neurotransmitters or neurochemicals that helps reinforce the state of wakefulness, but it also has a role in helping reinforce sleep continuity. So when it's missing, we get not only daytime sleepiness, but sometimes fragmented sleep during the night. So I think some of the well-known sleep architecture or fabric of sleep disturbances that are known in narcolepsy include this early entry into REM sleep, the excessive pressure to enter REM early and maybe have a little extra REM sleep. The so-called SOREM or sleep onset REM period is a characteristic finding, at least during daytime naps, but sometimes also during the night. But one of the chief difficulties, then, that pentad symptom of narcolepsy is the difficulty maintaining sleep. So patients with narcolepsy, as you all well know, can often fall asleep quite well, especially at nighttime, but also during the day. But they have trouble maintaining sleep continuously through the night. And as such, there are frequent arousals, most of these spontaneous arousals as part of the fabric of sleep, frequent shifts in the stages of sleep towards lighter and less restorative stages. We've been fortunate over the last decade or so to have a couple improved therapies that really help address this nocturnal sleep disturbance component of narcolepsy, and these are the oxybates. There is the well-known sodium oxybate, traditionally Xyrem, as well as what Dr. Silber earlier called today lower salt, I believe, lower sodium oxybate. I'll call it complex salt oxybate, or if you like, you can call it sodium, potassium, magnesium, calcium oxybate. I think that's a little cumbersome, but we'd just call it Xywave. But both of these not only improve cataplexy and daytime alertness, but have the quality of improving nocturnal sleep continuity and depth. So they'll decrease the amount of awakenings or arousals through the night. They will decrease these shifts toward lighter sleep and promote deeper sleep, at least with N3 or slow wave sleep, which we think is so important for brain health and brain functioning overall. Now, unfortunately, as great as these medications are, and we'd often like to prescribe them at will, we don't get to, unfortunately. That's a problem. Oftentimes with insurance restriction, these medications remain expensive, unfortunately. So sometimes we can still summon some of the old medications as well. Clonazepam can also be another effective medicine for promoting or stabilizing sleep, although I think has largely fallen out of favor in current practice due to the superiority of the oxybates. And hopefully this is another reason for advocacy by both patients and physicians. We can keep getting and expanding coverage for these newer and superior medications. Well, next I'll shift gears and talk about some of the comorbidities or the overlap of other sleep disturbances within narcolepsy. Most of these are well known and quite common outside of narcolepsy, but seem to be enriched or more frequent or more common in the narcolepsy specific populations. And so we'll start here with obstructive sleep apnea. Many of you may know that this condition results from repeated collapse of the upper airway during sleep and often is associated with loud disruptive snoring and stop breathing events during sleep. It itself can cause a form of sleepiness much like narcolepsy, and it also can confound or compound the state of narcolepsy and its sleepiness. It's quite common in the general population, probably at least 4 to 12%, but in narcolepsy, it's been estimated between 10 and 25% of patients. And I'm reminded from Dr. Carvalho's slide and from our own study even that it may be as frequent as about a third of patients with narcolepsy who have comorbid sleep apnea. Importantly, we think that the severity of sleep apnea matters. We define the severity of the condition by the frequency or number of stop breathing events per hour. And we'll call it moderate severity apnea when that hits a threshold of 15 stop breathing events per hour. So note that the average AHI or apnea hypopnea index stop breathing rate in narcolepsy is about 28 per hour. Well up into the moderate and almost into the severe range. So just as Dr. Carvalho discussed, we think that at this level, sleep apnea itself may add to the cardiovascular risk and comorbidity of narcolepsy and possible general health complications. Well, within narcolepsy populations, the predictors for sleep apnea are similar to the general population. Obesity and male sex and older age tend to be the main risk factors. Of course, obesity is also a bit more frequent within narcolepsy populations, so there's likely some overlap there that in part drives it. But it's also more complex than that. It's been noted that patients with narcolepsy with sleep apnea are also sleepier than narcolepsy patients without it. Some of this may be due to the fact that sleep apnea has been associated with lower CSF hypocretin levels in narcolepsy. It's not quite clear if that's cause and effect or merely association or exactly what's driving that. But many think that sleep apnea, when present, can be a kind of proxy measure for more severe narcolepsy itself. Well, how to recognize sleep apnea in narcolepsy, very similar to how we recognize it outside of it in the general population. The cardinal symptoms of this condition include loud disruptive snoring with snort or gasp arousals and witness stop breathing events during sleep, as well as the daytime symptoms of daytime sleepiness, headache, dry mouth, sore throat, and attentional or cognitive issues as being prominent symptoms of the disorder. Now, the treatment for sleep apnea is still number one when this problem is severe enough to merit treatment is CPAP, continuous positive airway pressure, which I like to distinguish from CPAC. It is not a PAC, but it's positive airway pressure or PAP therapy. This can be hard sometimes for patients to tolerate, and not everyone needs it, but when it's necessary, CPAP is probably still the best proven therapy, particularly to mitigate health risk associated with the condition. But in less severe cases where that's not really merited or not tolerated, positional therapy, keeping the patient off their back when the apnea is often worse, weight loss efforts, avoiding alcohol at night can be some of the helpful lifestyle approaches. Dental appliances are increasingly used for milder cases, and many of you have seen the every other minute commercials in the Minnesota Twins games for the Inspire device. This is a surgical implant, which can also help treat sleep apnea in those cases that have been unable to tolerate nasal CPAP therapy. Well, now I'll shift gears to talk about restless legs, please legs syndrome. I could shoot myself for the typo here. We have two legs and it is restless legs syndrome. This condition is typified by an uncomfortable urge to move the legs with relief after movement, particularly getting up to walk, and evening worsening. So many times this interferes with the onset of sleep and leads to an initial insomnia complaint in patients with this condition. The nature of the described symptom is quite variable. It has an unpleasant quality, often a creepy, crawly, tingling, or burning or aching sensation in the legs that accompanies this core urge to move. It can really be anywhere in the leg. Most typically it's below knees, but it can be one leg, both legs, switch legs, whole leg. It kind of does what it wants in this respect. And it's accompanied in most cases by periodic leg movements during sleep. These are involuntary leg movements that recur about every 20 to 30 seconds and sometimes additionally fragment the sleep or lead to arousal. Now, in the average general case of restless legs, two factors often drive it. Genetic factors or family history might even be number one. And number two is a link with low iron levels in the body. It's a bit mysterious exactly what's going on there, but low iron really compounds restless leg syndrome, and sometimes treatment with iron replacement therapy, either oral iron or in extreme cases, IV iron infusion, can really help the situation. The story is a bit more complex in narcolepsy per se. It does appear that narcolepsy is enriched for the co-occurrence of restless leg syndrome, but when this has been studied, it's been found that there's a less consistent genetic risk. There's less familial cases of RLS in narcolepsy populations, and there's a lesser link with iron deficiency. Now, either way, we still start with checking iron measures in our narcolepsy patients with RLS, and when the iron's low, fix it. That's often sufficient, but symptomatic treatments with medication are often necessary to improve quality of life and improve sleep quality. These days, the number one treatment has become the gabapentin or gabapentinoid medications. If you like, we can call them alpha-2 delta ligand medications. These have really gained greater favor due to their lesser propensity of side effects, but when necessary, we can often shift to the traditional dopamine agonist medications as well with caution and use this quite effectively for the treatment of RLS. Well, last, I'll say a few words about parasomnias, and these are undesirable and often unusual behaviors that arise from the sleep state, and there are different types of these. REM parasomnias are perhaps most common, particularly in the form of isolated nightmares, or in the case of narcolepsy, overlap with part of the tetrad of symptoms, that of sleep paralysis. So the theory here is the patient may arouse from sleep and have an intrusion of REM atonia or REM paralysis into the waking body. So that's a little bit of a unusual phenomena. Usually it's a benign phenomena, but can be quite frightening for the patient. When you have sleep paralysis without sleepiness, it doesn't mean you have narcolepsy. This is actually quite a common isolated symptom for isolated sleep paralysis in the general population. It does seem that narcolepsy is also enriched for a peculiar REM parasomnia called REM sleep behavior disorder. This is a condition in which the normal paralysis of REM sleep is lost or dysregulated. And it seems to be just another symptom of narcolepsy when it occurs in that illness. So REM sleep behavior disorder leads to often violent motor activity or vocalization during sleep, where patients may flail their arms, punch, or kick in reaction to a nightmare. The risk here particularly is that of injury during sleep. So we have found that melatonin, plain old over-the-counter melatonin, can help mitigate that risk and control the behaviors. When needed, clonazepam a prescribed medication can also be used. Similarly, for the non-REM parasomnias, these medications often disorders often benefit from clonazepam treatment. This is a spectrum of behaviors that result from an abnormal arousal from non-REM sleep, and it can take a spectrum of different symptoms, including sleepwalking, sleep tears, or merely a confused state. There can also be within narcolepsy a so-called overlap parasomnia disorder, which is actually a mashup disorder in which the patient has both REM sleep behavior disorder and non-REM parasomnia. So I will conclude here with a few final points. Narcolepsy itself does disturb nocturnal sleep, and the sleep disturbance leads to shallower and fragmented sleep that can often benefit from one of the oxybate therapies. Sleep apnea is a frequent comorbidity within narcolepsy and often requires its own treatment to mitigate health risk. Restless leg syndrome, often associated with iron deficiency in the general population, perhaps somewhat less so within narcolepsy, and that often may require either iron replacement when the iron is low or specific pharmacotherapy to treat it. And REM sleep behavior disorder and the non-REM parasomnias may both occur in the context of narcolepsy. And at least for RBD, we found melatonin may be effective to help mitigate the risk for injury. So I will leave it there. Welcome any questions at my email listed there. And thanks for your attention.
So I've been told that exercising too much, too hard can have a negative effect on narcolepsy. Can any of you speak to that? And is that true?
Before bedtime, that sometimes can be, in some patients, can be activating. Um, Exercising too much, I mean, excess is not good for anyone, right? Particularly at once. You're gonna hurt yourself. You can get overly tired, right? That's the extent I would be concerned about exercising too much. The recommendations in terms of health is a balanced exercise, right? Is the 20 minutes a day, 150 minutes a week, right? That appears to, some people like to do exercise in the morning to help with the alertness as well, before they go to work, right? But I think overall, excessive exercise is not good for anyone, patients with narcolepsy or not, because of risk of injuries and so forth.
Dr. Emery Morse. You guys know who that is? She's dope. And I only bring her name up is because she likes to talk on her TikToks and social media about these things. So this is more or less a comment than anything. Because she spoke to that. I asked her something and she used the term pentad symptoms, and it's just really cool. And I appreciate you guys going up there and sharing all that. I do have a question when it comes to these the mental health side, and I don't know if this is going to be discussed later on, when recognizing narcolepsy as a disability. Like a lot of the times on the support groups and what I hear from doctors and whatnot is they just chalk it up to saying, if you just take care of yourself and go on walks and drink more water, like you should be able to function like everybody else. And I don't know, as a patient, I hate hearing that because like it is debilitating. And I don't know whether these need to happen more often, or maybe the doctors need to hear it more often. But I would just push for not just chalking it up to that. I mean, almost everything that you guys said as far as the management of symptoms is something everybody can do, right? Able-bodied people, correct? There's some people without narcolepsy who aren't so able-bodied. So it's like, yeah, we can all eat better and try to go to sleep and, get some sunlight. But I think that's not it. Medication is a thing. I agree. But from a disability standpoint, having narcolepsy be recognized as a disability, I don't even know if I'm asking you a question. Yeah, there's no question. I just wanted to know what your guys' I guess viewpoint of that is. Could narcolepsy be considered a disability?
So the disability law, I think, and we've dealt with this quite often, is not always or not mostly condition specific. So it is how severe a condition is and what the limitations secondary to that are. And if the condition is severe enough where the symptoms preclude you from working, yes, that is the reason that we have disability. It's so people who cannot work, there is this safety net. And I completely agree. There are situations where people with narcolepsy should qualify for good reason. And we sometimes do end up seeing that happen. So I don't think that it is excluded as such, at least not to my knowledge.
Yeah, it's pretty much based on symptom control, right? There are patients with narcolepsy that can function very, very similar to any other person on treatment, right? Not off treatment. In that case, they wouldn't qualify for disability per se, because they're able to function. So I think it depends on the case.
Yeah, I guess I'll just add, I mean, I think it's incumbent on us as physicians to try to optimize, for each of our patients, their optimal function. And everyone's going to be different in that respect. So we've certainly seen cases where disability became necessary. I would want to emphasize, I think, on the average, that narcolepsy is highly treatable and remediable, although with some precautions that our current treatments do fall short. They're often not totally optimal for alertness and complete mitigation of cataplexy and other symptoms. So, yeah, I'll leave it there.
Yeah, hi, Tom Heckmaster here. With the cardiovascular comorbidities with narcolepsy, is there an understanding of how much are perhaps caused by the medications used to treat it versus the underlying disease itself?
Yeah, great question. It's a major interest of the current research and calls for more research in that field. We don't actually know. Okay. I, most likely than not, we're gonna have more than one culprit for the problem. Okay. And as I discussed with you, the orexin reduction, the fragmented sleep, will be playing a role. So it's going to be hard to exclude those things as contributors, but how medications will play a part on it, that's the $1 million question that there's a lot of push to try to answer, but we don't have the exact answer to identify, the independent effect. We wish you could know which is the best medication for someone with cardiovascular disease or with an increased cardiovascular risk, but I don't have that answer.
So this is a actually very complicated question. So there are various aspects to it. So if we just go to the medication side of things, most of the drugs that were used earlier, the stimulants, have been around for a very long time and have been used to treat ADHD. So at least in psychiatry, we have a wealth of epidemiological data looking at patients who've been on these medications very long term, and we think they're extremely safe, at least in psychiatry. There is a slight increase in blood pressure, slight increase in pulse rate, but cardiovascular risk as such is not a major problem. With the other medications, they're relatively new. So the Sunosi, Vakix, we don't have long-term data to tell us if there will be any cardiovascular signal. I suspect not, but we don't have that. With sodium oxybate, in theory, the high sodium can have cardiotoxic effects, but there's really no reported case of a cardiotoxic effect secondary to that. So yes, in theory, maybe not. Then moving away from the medications to the epidemiological side of things, if we look at any chronic condition, we will see that they are associated with more morbidity than not having a chronic condition. So is that narcolepsy specific or not is going to be hard to tease out. And in epidemiology, we see this. So when you look at narcolepsy, there is so much comorbidity with sleep apnea, with restless legs. A lot of that is sort of muddied waters because people come to a sleep center for sleep problems. We find narcolepsy, but we are looking, so we will find many other things too. So is that because they have more of it or just because we've gone looking? We don't know. So that's the long answer to say we don't know.
So this is more kind of your opinion going forward. What do you think is going to happen with the comorbidities as we get these orexin agonists coming out? And how will that change the comorbidities down the future? Or do we have more hope to think that these comorbidities might not be there once these new medications come out?
I think it will depend on what the agonist will do with the sleep architecture. That'll be one thing to look into. As Dr. Suba discussed, it seems so interesting how there are orexin receptors in many different parts of the brain. Okay, so will the agonist bind to them in this widespread, connections to the point to reverse the very deficiency that we see in narcolepsy type 1? If that is the case, there will be hope, right? That there could be a significant decrement if sleep is normalized, right? And other things are normalized. So yeah, we're all excited about this possibility. In a realistic, what I feel personally, that may improve some, but not necessarily, correct the full problem, because orexin also is not something that there are pulsations of the orexin neurotransmitter, including during REM sleep. Is a very, very complicated regulation. That's why it sounds like orexin is related to the lack of orexin is related to the REM sleep behavior disorder even. So no medication would be able to emulate, these fluctuations in orexin in our body in the same way that the natural orexin does, but in the natural regulation. But can it suppress some of the deleterious effects of not having it at all, or very diminished in the body? I think it will.
Okay, we have one virtual question, and forgive me, I don't know how to pronounce any of this, but can Effexor cause my MLST to show now REM, but asleep within 3 minutes?
Okay, I will do my best. So I'm actually just going to answer a very generic question as to what can Effexor do to your MSLT. So Effexor is venlafaxine, and SNRI. It is an antidepressant, and venlafaxine especially, but most of the other antidepressants can suppress REM. So if you're taking the medication and you go through multiple sleep latency testing, it's very likely that even if you have the narcolepsy specific sleep onset REM episodes, they get suppressed. We don't see them. So what we try and do in preparation for this testing is get patients off the medication, and we try and do it at least a week or two, preferably 2 in advance of that, because when you've immediately gone off of it, there can be a little bit of what we call REM rebound. So you get into REM a little more quickly. So we don't want to do that too close to the testing. So if you go off too close to the testing, that is a possibility. So that's my answer.
Tolerance levels when it comes to like the medications that are prescribed. So I've not had any success with Xyrem or Wakix. And I've been on Adderall for a long time. So I'm just kind of curious. I guess I'm not sure. My question is, so with getting a higher dose to make up for the tolerance that I have, that would obviously come with more side effects. What do you do for someone, I guess, tolerance issues, or I guess in my situation, maybe? I don't know. Sorry.
Well, the honest answer is I don't know either.
So I was just kind of curious what happens.
So the classical teaching has always been, and it has borne out in my clinical practice for the most part, in that once we get to a reasonably stable dose of a stimulant, so Adderall or Dexedrine, that's keeping people reasonably awake and alert, the vast majority won't need much changes. But each person is different. Vast majority does not mean everybody.
I guess, what is the max? So I'm at 90 milligrams a day, which overall, I mean, I don't have any side effects. It's working, but I think that to get that level that you're talking about, maybe a slight increase, but my doctor's, with regulations and everything, she would really like to knock it down a lot farther and keep it there. But I guess, do you see higher doses with people with narcolepsy that without issues?
Rarely. So without issues, again, is a very loaded.
Well, yeah, okay, I guess.
So we want to try and practice within FDA limits for upper limits of the doses. The things to know, especially with stimulants, is most of that literature is coming from ADHD and not from narcolepsy. But that said, the FDA has those limits because they are concerned that when we go past them, the risks go up. So when I say stimulants are very safe, they're safe when they're used within those FDA recommended doses. And once we go beyond, all bets are off. So is it safe? Possibly. Can we be 100% sure? We can't. So the risk is there. And then it becomes this act of balancing. Is the benefit outweighing any potential risk? And for each patient and each prescriber, that's an individualized answer depending on the situation. I don't know if the others have any more.
Yeah, no, but I'll chime in. I mean, I think I would comment too. I echo the sentiment or understanding that the tolerance phenomena, once we've reached steady state and a good outcome, is rare. But it does happen. And so your options when that happens are, one, tweak the dose, as I think has been done in your case. Number two, consider an adjunctive medication or an enhancer. And that could take the form of one of the other wake promoting drugs, the Sunoses, the Wakix, the modafinils of this world, or the oxybates. And number three, I'll add to highlight the talk that I gave is think of another sleep comorbidity, because sometimes if that tolerance comes late, it is really increased sleepiness due to some other problem that needs to kind of be reinvestigated.
Yeah, I completely agree. There's one additional thing that I see when patients come and say, "Yeah, was doing well, now I'm not doing as good, and I still feeling tired." It's kind of clarifying what this type of tiredness is. If it is a problem of alertness, then doing the tweaks they're talking about, those considerations are very relevant. When it comes down to another problem, which is fatigue, which often overlap with sleepiness in many patients. I know that in narcolepsy, the sleepiness is the predominant thing, but sometimes, things in life happen, other things, right? That can bring that fatigue up to the picture, and people are hoping to get the benefit of the stimulant on the fatigue. And so I see people that come to me already increasing doses to really high for the fatigue, but the fatigue is getting worse because, stimulants, unfortunately, are not very good for the fatigue. In multiple studies in different conditions, it hasn't shown to be very effective for fatigue, unfortunately. Occasionally I see a patient when they notice an improvement in the fatigue, but the stimulants overall are not. And occasionally it can worsen the fatigue when they give that post-dose kind of crash the patients have, right? So you have to be very careful what is actually the symptoms that are residual here, because if it is fatigue, then bumping stimulants may cause more side effects than actually benefits, unfortunately.